This week on Core Ultrasound Image Review, I'm going to share with you a recording that Taryn Trott, Ben Smith, and I did the day before the content creation and ultrasound management course. It was a bit of a sound check, but we were able to share with you guys live a few clips. Now, if you want to watch the content creation and ultrasound management course, head over to courses.coreultrasound.com and you can register to watch it there. Now, as far as the clips themselves, all of the clips that we talk about are actually available on the Core Ultrasound clip bank. These are downloadable MP4s that you can use for non-commercial purposes. And there's also explanations for each video individually. So you can click on them, download them, and then if you want to know exactly what you're seeing, you can click on the I icon, like the letter I, and a video will pop up with me explaining to you each of those specific clips. So I think it's an amazing educational resource. We worked really hard on it. Check it out. Go to the Core Ultrasound website, click on Clip Bank, and they should be all available for you there. In the meantime, enjoy Taryn Trott and Ben Smith and I going through these clips with you guys.
All right, the first clip. Now, Taryn, that was a very short clip. You have not seen this clip.
Mm-hmm.
This is very exciting. It's kind of rare.
So the first thing my eyes are going to is like, what kind of probe am I using? Right.
Okay.
Let's start with some of the basics. I see a curvilinear probe.
Mm-hmm.
I know that because.
Do you want to use the cursor?
Yeah. I know that because the top is curved. It looks like we're getting about the right distance.
Yep.
And then I see probably some soft tissue up here. And before we get to like the glaring thing in the middle, I see a lot of hyperchoic stuff on the side.
Yeah.
I already think that's probably bowel.
Nice.
I see a hyperchoic structure down here with some shadowing behind it. I think that's probably a vertebral body.
Yep.
And then let's look at the big anechoic structure here. Anyone have any thoughts on what that is?
Ben, do you have any thoughts? I have a sagittal view coming up, by the way, but just based off the transverse view, what are you thinking?
Well, from the location, it's right above the spine there. And so I'd be worried about big red in the belly.
Big red in the belly.
Big red in the belly. But why does it look so weird? I feel like it looks really weird.
Yeah, it does look kind of weird. I mean, it's like, it almost looks like if that is the aorta, it kind of like goes, I'll say that little pouch comes right off of it,
Yeah.
Yeah. It looks like some kind of saccular aneurysm or something like that. With our first initial images here.
Yeah.
This is 100% one of the examples where you're going to want to get more than one view to really figure it out.
Isn't this fun? Look at this thing.
Look at that guy.
How many times have you seen this, Ben?
I don't think I actually ever have. This may be number one. Maybe twice, maybe once before.
I think that this is a really good example of why you should scan the aorta from basically the epigastric area down to the split, because if you only looked like here, you would say like, maybe it's, I don't know, like 2 centimeters under the normal limit. But when you look here, this has the same like badness associated with it as a fusiform aneurysm.
Yeah, that's a great point. You'd totally miss this if you just were hitting a couple slices.
Yeah, exactly right. And then another like kind of rare finding that I don't see very often. You see that right there? So right here, this little outpouching of the aorta. So this is definitely an aneurysm because it's above 3 centimeters. But if you look at this right here, it's enlarged. It's like a pre-aneurysm. When it's larger than, I forget what the actual like limit is, but if it's larger than a certain limit, it's called focal ectasia, which is like you go from like normal to ectasia to aneurysm.
Gotcha.
So you see this little outpouching, it's less than the 3 centimeters, then they don't need like an emergent surgical consult, but it is an abnormality that the patient should know about and should kind of monitor moving forward.
Now, sometimes when we look at aneurysms of the heart, there's a distinction between pseudo-aneurysms and true aneurysms. Oof. Is there a difference for the aorta?
Ben, do you know like how to tell the difference between a pseudo and a full aneurysm or regular? I don't know.
I'm not sure.
Well, the histological difference is that it includes all like layers of the wall if it's a true aneurysm.
70 on step 1.
Somebody's a nuclear engineer.
Wow.
Yeah.
So all you have to do is just take a biopsy and then you'll know.
Biopsy the aorta.
I'm actually not even, I've never seen a pseudoaneurysm of the aorta before.
That's a thing.
Yeah. So, I mean, like I think of pseudoaneurysm in the context of like, a vessel's been accessed and then you've got bleeding outside that, through that vessel. And so like you basically have like a little pouch of blood that is almost like an active extravasation, that's pseudo-aneurysm, where there's some blood going into it, that's being expelled from the artery. And you see that commonly with like, after somebody's like a post-cath or something like that. But I've never seen that described with the aorta.
But I mean, yeah, it's still like, I mean, using this data and extrapolating out to like, the axillary artery, let's say, I'm wondering if you can tell the difference. Like I wouldn't, besides the biopsy, which we're being sarcastic.
Don't do it.
Don't do it. Don't biopsy it unless you're trained to do it. I don't know. But I'm wondering if like on ultrasound, if you actually would be able to tell the difference. I don't think so, but I don't know.
Maybe some flow abnormalities. I don't know.
Yeah. Who knows? All right. Next image here. Ben, do you want to take this one?
Sure. This is the phased array probe, because the wedge comes to a point at the top there.
Nice.
And it's a real contrasty image, probably on cardiac mode. It looks like this is probably an aortic arch view.
Yep.
We're kind of looking up at I believe we're looking up at a dissection there. It looks like the aorta has a flap in the middle. It's like something hyperechoic. Actually, I see kind of like two lines, even a little bit faint one on the
stripes on a watermelon.
Yeah.
I think it looks like someone's like plucking a guitar string, like twang, little harp. Yeah. This is this.
Why don't we have music to this right now?
We should.
You're right.
We should. We'll do it in the post processing. This is a descending aorta, and this is a big old dissection flap in there. Which this view, you place a trans. Can you see me, Ben? Out of curiosity, or can you only see the screen?
I see both. I see a little thumbnail of you up there in the corner. I can see what you're doing.
Perfect.
Yeah.
I just want to make sure. So basically you stick the transducer here in the suprasternal notch and angle it up. Now, usually what you have to do is you have to make the patient turn their head so you can bring the tail of the transducer up there. It's not a super easy view. And I don't usually do this a whole lot when I'm doing like scan shifts, for instance, because it's a bit uncomfortable.
Yeah.
But if I have a patient with a high suspicion of a dissection, some kind of pathology that I need to see the arch, he's kind of pushing.
You also just kind of fill this notch with gel.
Yeah, that's true. Good point.
Fill the entire cavity of the suprasternal notch with gel.
Yeah.
I had a really, I think I showed you the images. I had a very convincing dissection flap.
Oh my gosh.
High pretest probability patient.
Looks like a dissection.
Like, 240 over 180 or some ridiculous blood pressure, chest pain, no back pain, not all of it, but I was convinced on my ultrasound, and I had to take it to Jacob because
and I was also convinced.
We were all convinced, and the CTA was negative.
So weird.
So we had to troubleshoot it. So how do you feel about using ultrasound to rule in, rule out dissections?
I mean, that's a good argument. And Ben, I know that you have most of my thoughts on this are based off of you teaching me about like Bayesian analysis of stuff, but for me, I use this mostly for the specificity. So I never use the ultrasound to rule it out. And if I see it, most of the time I'm comfortable saying it is. Are we going to be right 100% of the time? Probably not. But I think that it is useful enough with its specificity to use it for that. What are your thoughts, Ben?
Same. I mean, especially when you're thinking about a thoracic dissection, I feel like if I see it, it's almost always there. I've never had a case. Well, I'll take that back. I have had one false positive, and that was where sometimes when you're doing that, the descending thoracic aorta view from a peritoneal short, like that halfway between a peritoneal long and peritoneal short, sometimes you'll get an artifact that reflects off there that kind of looks like a flap in there. I think it's because you're hitting. Go ahead.
Yeah, no, 100%, and that's the conclusion I came to with the one, my false positive. But then, to try and counter that, you look for an artifact. To rule out an artifact, you look for something that's moving independently of the structures around it. Like in this dissection flap, we see that guitar string plucking.
It's moving separately from this. There's no movement up here that's also movement down here. There'd be like a weird mirror artifact or something like that.
Exactly.
But there was none of that with this image. Like we should probably show it as like, and we'll send it on Twitter and just ask people like if they have any advice for it. Because Ben, it was quite convincing. It was quite convincing for a dissection. Like I would have been like, it's a dissection.
Another thing that they think that'll help you is if you throw color on it. I'm not usually a huge fan of color, but color will be, absent or reversed even like in the false lumen.
Yeah, brilliant. And that's actually something that Hari Kalagara actually mentions in the chat. She actually said color, or, you know, how do you know if it's an artifact versus a dissection? And I think kind of what you're saying, Ben, is, yeah, I think color would be like a good thing to help there.
Yeah.
Sweet. Shall we move on, Ben? Oh, this is normal over here. This is ascending aorta. This is the arch. This is descending aorta.
It's a really nice
Subclavian.
view.
Thanks. This is mine, actually.
That's your
This
arch?
is literally my arch right here.
Nice.
Thanks for saying that. You did. That's very sweet of you. This is a subclavian. This is a carotid over here.
And sometimes in the middle here, you can see the
right
pulmonary veins or
arteries.
arteries.
Yeah. I don't think you can see it with this one. It's just like my arch fat right there.
So on that view right there, you've got ascending arch on the left, correct?
Right here. Yep.
And so with the probe marker in standard cardiac view, which way do you have, start with the probe dot, I'm sorry, with the image dot on the right side of the screen, which way do you have the probe marker for this standard view?
In this image, I have the probe is here. And so I have the probe going to my left. Wait.
Towards the
wait, I have to think about it.
Patient.
So this would be the right side. Yeah. So I have this going to the left. Yeah. And honestly, like with the arch, like, I don't know if it really matters if you're like, this is ascending and this is descending. I don't know if that matters as much as understanding that is the arch and knowing that there's a flappy thing in the arch. You know what I mean? Like, in fact, this image over here, I'm like very certain that this is the descending aorta, but to be honest, I'm not like 100% sure. You know what I mean? Like, I don't know.
If it's the same convention as the one on the right, then that would be,
Yeah.
I typically leave it in cardiac mode and put the dot towards the neck.
Towards the back.
Yeah.
Okay. Brilliant. Yeah. Oh, that's the other thing too, is that you have to be a little bit kind of like tilted a little bit. You can't just be straight to the left or straight to the right, because the arch kind of goes towards the back. Exactly. That's a good point.
Yeah.
That's a great point. All right. Sorry, this one's not in full color, but
it's a WandaVision version.
This is the WandaVision version. The WandaVision episodes 1 and 2 versions. So this is one that we uncovered. Now I'll tell you the story. This is a patient that comes in with bilateral leg coldness and numbness.
Bilateral cold leg and numbness. I'm thinking IVC pathology.
It could be IVC.
Or I'm sorry, or aortic pathology.
Aortic pathology. That's what he meant.
I just had an IVC.
He meant that. He meant that. So this is the spine right here. This is the anterior arch of the spine shadow. This is an aorta that is 100% occluded. And we know that because there's a bunch of smuts in there, right?
Yeah.
And then B, all this color flow is just basically showing all the collaterals, because that's why the patient, like, it has the bottom half of their body hasn't rotted off, right? Because of the collaterals. But with the color flow, we can see that there's good color flow around it, but none on the inside. Yeah. And this is a poor prognostic sign, although this patient did have plenty of collaterals. And that's why, like, I think one of the collaterals, like, they were kind of failing, or they kind of clotted off. And that's why the patient came in symptomatically. I mean, this didn't happen overnight. You know what I mean? Ben, do you see this a lot, or is this like a pretty rare finding like it is for us? Like, we don't.
Super rare. Yeah. I've seen it maybe one other time. I don't think I've ever actually seen it on ultrasound. On this one, I would be, whenever I see something like this, where I've got, a circular structure, I would just confirm as you fan through that is continuous, that structure is contiguous with the rest of the aorta. And then the sagittal view can really help you there, I think.
Yeah, that's very true. Because
like some retroperitoneal mass or something like that, it's hard to say with just one view,
That's actually a really good point.
I had a phenomenal scan in fellowship. This person had
which one of your 2 fellowships was it?
Which one? Critical care fellowship.
Okay.
It was a surgically removed aorta. So this person did not have a continuous in the aorta from
oh my goodness,
top to bottom, and had bilateral axillary fem bypasses.
That's fascinating.
And so you could scan through the belly and see the aorta, and then it stops, and then you pick it back up at the iliacs. It was insane.
Wow, I didn't even know that was possible.
I did not know it was possible either.
How do you perfuse the gut?
The vascular, it was just a little bit. It was right above the iliac. The vascular surgeon had drawn the schematic because they were getting so many questions on what exactly is in this person's body.
Like drew it.
Yeah, and it was like posted like on the computer next to the patient. Right?
That's fascinating.
Yeah.
Sweet. All right. Oh, okay. So these are 2 different pathologies. Ben, I think that you were around for one of these, and the other one I think I had when I was in the current job that I have now in Kentucky. I'm going to walk you through. Like, can I walk you through these?
Sure.
So, Ben, can you just say yes or no? Do you know what these are?
The one on the right is very familiar. So I'm pretty sure I know what that one is.
Together. Yeah, we had this one together. So this is a subxiphoid view. This is the liver up here.
Mm-hmm.
And there should be, if this is a subxiphoid view, there should be a heart, a beady thing right here. We see a little bit of kind of movement of there. And I'll tell you that the patient is definitely alive. Okay.
Yeah.
And we're seeing something interesting. So we see kind of a brightish hyperechoic line right here, much more bright than you normally see the capsule of the liver. And then you see these reverberation artifacts on here.
That's what my eye is going to.
They're A lines.
Why are there A lines in the subxiphoid view?
Right, exactly. So A lines, you got to think about how artifacts are formed. Artifacts are formed, A lines specifically, when you have a uniform layer of air, and it creates like a reverberation artifact between a layer of air and something else. Exactly. Yeah. So for some reason, instead of the subxiphoid view showing the heart, we're seeing a uniform layer of air with A lines beneath it. This is, I'm going to say it wrong because I always say it wrong. It's pneumomediastinum. Mediastinum?
I know you want to say mediastinum.
Pneumomediastinum is, how do you say it, Ben?
Mediastinum. I think that's how I'd say
it. It doesn't matter. Tomato, it doesn't really matter. But this is air in the mediastinum? Mediastinum. Yeah. Yeah. And I think that this one was spontaneous. So this is pneumomediastinum, and then this right here is the other one. This is pneumopericardium. So we can actually see the heart here. We see a little bit of fluid here. I will tell you that it's blood. And then we're seeing the other type of air artifact, which are B lines.
B lines.
Yeah. Ben, do you have any idea as to why we're seeing, and I have theory, right? Why we're, I went too far. Why we're seeing B lines in this situation and why we're seeing A lines here? Any ideas?
I mean, when I think B lines, I think, some air mixed with fluid, like kind of, bubbling around together and causing a bunch of little reverberations, like you would have like a little bit of fluid and air and an alveoli together. And so it's almost like the same artifact, but it's much smaller, like reflection surface. So the distance is smaller. So it looks like one continuous like artifact, but in fact, it's almost the exact same thing, but the A line reflection distance is so much smaller. In fact, you can almost think of A lines as being the same as B lines, but B lines are like super, super small distance between the air and the fluid.
Yeah. So this one right here is pneumopericardium on the left, where it was a gunshot wound and it struck the pericardium. So that's how the air got in the pericardium. Now, I don't know if you can reliably say that every time you see A lines, that's definitely going to be pneumomediastinum. Whereas every time that you see B lines, it's pneumopericardium. I don't think that there's enough data to prove that. But this is the situation which I've seen pneumomediastinum has been A lines, and where I've seen pneumopericardium has been B lines.
Interesting.
Also on the one right there where you see the liver.
Yep. Wait. You can see liver on both, Ben. Left or right?
Yeah, you're right. Right. On the one on the right, when you're looking in the belly, you can also see A lines.
That doesn't make sense. A lines only come from the lungs, Ben.
In the setting of pneumoperitoneum. That's right. So free air.
Nice.
Although I will say, I have occasionally seen them as a false positive, but you have a patient that has what seems like a perforated viscus, and you look up in the belly, and you'll see A lines, and that's, you don't. When the air is in the bowel, there's air also in the bowel. When there's air in the bowel, you've got that sort of irregular, anterior bowel wall that the air kind of sits against, so it doesn't actually reflect perfectly. So you don't have A lines when you have regular bowel, but when it's free air, you can actually develop against that smooth peritoneum. And that air level, and then air level you get between the skin and the peritoneal surface, you get the A lines that form.
Cool.
There's actually a sign called the enhanced peritoneal stripe sign. So it's basically like kind of describing what you're saying, Ben, where you'll see like the peritoneum be like a little more hyperechoic, but not super bright. Right next to it, you'll see a super bright line and then A lines underneath that. And that's like, some people have described that as being like indicative of pneumoperitoneum. And I will say that if I have somebody that's got a lot of toots in their belly, I've seen A lines. They're not consistent, but I've definitely like seen A lines in the belly. But most of the time I see A lines, especially coming from a extraperitoneal or enhanced peritoneal stripe sign, definitely more likely to be free air in the belly, which is no bueno.
No bueno.
All right. Any other thoughts or comments, Ben?
If anybody wants to find the free air in the belly, look for somebody that's like post-op abdominal pain after a laparoscopic surgery, and there'll be air there. So that's a good one to practice on.
Brilliant. All right. I got two. Oh, get back there. Ben, which one is tamponade and which was a tamponade? I picked these because these are very similarly sized effusions, right? Yeah. They're probably the same size, but one is tamponade, one's just an effusion.
Yeah. So the lowest pressure. This is for me, right? This is me.
Yeah, this is you. This is all you. You answer, please.
Okay. All right. So the lowest pressure system in the heart is going to be affected first by the pericardial fluid. So as that pericardial fluid starts to affect the heart, the RV and the RA start to get sort of compressed in at different points in the cardiac cycle. So I'm looking up a little slice of the RVOT is where I'm focusing, and the one
So you're talking about this up here,
Yep.
or this up here?
That right there. Yeah.
Yeah.
So like that little like anterior RV wall there, the RVOT wall there, is going to be one of the first affected portions of the RV. And on the right, it looks like it's doing pretty good. On that screen right clip, it looks like it's just contracting during systole. No, I don't see any collapse, but on the right, it's bowing in a little bit. So that RV on the screen left, that one right there, screen left, looks like that RV is kind of like in trouble.
Yeah.
Brilliant. And actually, Hari Kalagara actually mentioned that almost immediately.
Yeah.
They were like left tamponade. It totally is. Now, Ben, we don't have I don't want to say like there's like a debate between us. We just have a healthy discussion about tamponade. We've had this before. First off, nomenclature, right? So we want to make sure that we're looking at diastolic collapse, right?
RV diastolic collapse.
Right.
Right.
And then the other thing that I'm not 100% sure that Ben and I agree on, which reasonable people can disagree. Now, Ben, you say, if I remember correctly, you say right ventricle diastolic collapse or right atrial systolic collapse. Is that how you describe it?
Yeah, although to get into the weeds a little bit, it's right atrial collapse during reticular systole.
Yes, that's right. That's right. I mean, for me, I always think
even the literature, when you look at these, there's inconsistencies in the literature on how they're describing the atrial collapse.
Yeah,
I mean, it's the same concept. Right atrial collapse during atrial diastole wouldn't be that significant.
Right. Yeah.
It's so low pressure anyways. You could get that in all sorts of physiologic states. So if the atrial pressure is supposed to be at a high and it's collapsing, then that would be more indicative of a problem.
Right, exactly right. And when you look at the literature says that the right atrial diastolic collapse, and that's collapse of the atria during atrial diastole when it's supposed to fill it. That's actually the earliest finding for early tamponade, which another
because it's so low pressure.
Yeah, exactly. And then another discussion is like the difference between and I talked about this sonographic and clinical tamponade. Yeah, and we talked about that, and we've been about like is it a clinical diagnosis or is it a sonographic diagnosis? And I think there's arguments for both. I forget who it was, but it was somebody on Twitter said the question, and I'm paraphrasing, the question shouldn't be, is it sonographic or clinical tamponade? The question is, how soon do you need to stick a needle into it?
Right.
Which I think when they are hypotensive, they're crashing, they're not perfusing, you definitely have to stick a needle in it. But if you see sonographic evidence of tamponade, it doesn't necessarily mean you have to do something about it that second, which I think is important.
Yeah, that's tough. And you're going to see a lot of practice variation on that for sure.
Yeah.
There's going to be interventionalists that are more aggressive versus those or others. And then, even the characteristic of their fusion, they'll think, do I have a safe target? I know that goes a lot into people who are tapping these routinely.
Right.
Versus maybe delay a little bit if you don't feel like it's the risk benefit. You might poke the RV or something,
Ben, what's your favorite location? Like, if all things being equal, do you prefer subxiphoid, apical, or peritoneal long for your stabbing?
For tamponade?
Yeah. Like if you're doing a pericardiocentesis.
To answer your question, all things being equal, I like the apical view. If I can get a good view of the right ventricle and the right atrium. Yep. I mean, I feel like this. You have a little slice of the RVOT, but it's it's not. You're not really fully seeing the RV.
Yeah.
So I like the apical view best.
I think there's less risk to other cardiac anatomies, slicing a coronary or something like that.
Yeah.
Oh, you're talking about for the approach for to actually to get the fluid.
Oh yeah.
Yeah.
Sorry, I thought. Yeah.
Yeah.
So that was what the question was.
That's actually a good point. So for me, I like the apical and the peritoneal long because I think the distance is shorter and you're not piercing the diaphragm and the liver, which you almost invariably are with a subxiphoid. If you have a small pocket, it actually, and I hadn't thought about this, so you just mentioned it, it's probably safer to go subxiphoid because if you happen to accidentally poke the RV, probably less of a bad thing than if you hit, the LAD.
Right.
by
So-
going to the left heart, the back of the heart.
And I've heard that discussion. I don't know what the data is behind it, but that's what I've heard apical for. If you're going towards the apex of the heart, the only thing you're going to hit accidentally is the apex of the heart, which
There's
is
nothing there.
which is lower
Brilliant.
risk.
I
Yeah.
hadn't thought about that either. It's great. That's what we have Taryn here. All right. Ben, you want, or it's your turn. No, you go.
Okay. All right. I'm seeing a heart that's not doing so good. Either we have the probe backwards.
Oh, that's good. Now let's assume the probe marker is here.
Other way.
The probe marker is over here. Okay.
All right. So then we're seeing a LV on the right side and an RV on the left. We're in the apical 4-chamber view. And overall, I'd say the view is pretty good. I'd say we have like 85, at least a B plus.
Okay.
I can see the right atrium very well.
I took this clip, so
In
I
that case,
appreciate
it's
the B plus.
I'll give you extra.
No,
credit
it's you know what? It's fine. Okay, it's fine. Just kidding.
But I mean, I would like to see maybe the left atrium a little bit more open.
Yeah.
Because I know where this is going is we're going to compare RV to LV size. And if we're a little bit clockwise or counterclockwise on our probe, you're going to diminish or exaggerate the LV, which is important. This is part of the discussion here. Definitely is what the RV is doing by comparison to the LV.
Yeah.
So when I see that left atrium a little bit small, I think maybe we're foreshortening the left side a little bit, but nonetheless, we got a big old RV. Let's get to the point.
It's huge.
Big
And then we have
RV.
this up here.
That's for sure McConnell side.
McConnell. So we have hypokinesis out here. We have hyperkinesis here. And here, just to compare the two, on the right side is a normal apical 4-chamber, and on the left side is a not great apical 4-chamber.
And so, you know, like we were just talking to the residents about RV, a lot of RV strain stuff, and TAPC is an indicator of RV failure. And I was saying, I don't, you know, if I see a patient with a big RV and they're in shock, but their TAPC is normal, I usually use that as a sign that there may be something else going on. If you're in shock and you have a normal TAPC, I don't care how big the RV is, your RV is functioning. So
that's not the problem today.
I don't think it's the problem today. You got to take that with a big grain of salt and how it fits into everything. The last patient this came up with, they were also febrile. And so they were septic. Their RV was big, their TAPC was fine, they were septic. But so on this one, you could, oh shoot.
Go back. All right. Sweet.
So you could visualize that TAPC on the left heart, and you can see that this annular.
You mean the right heart?
Yeah. On the left heart, on the right heart of the left heart on the screen.
Is it the right heart, which is on the left side of the screen?
Yeah. So, and then you can see that this is not, their excursion here is not very good. So if we took the time to do a TAPC, this TAPC is maybe a centimeter is my guess. Versus look at this one.
And it's 1.6, right? Is the cutoff if it's above
1.6, 1.7.
Okay,
yeah.
okay.
Different literature. Versus, look at this. Look at the excursion on this one. So that's also like, you know, you don't have to do the TAPC every time, but that's what your eyes should be training to when you're assessing visual estimation.
Yeah, that makes sense. And then a couple of things for identification. Simon actually brought this up. Good point.
Very good.
That usually the tricuspid valve is a little closer to the apex. So if you look here, the tricuspid valve is a little bit higher than here. And I don't have a great view of it, but you can also sometimes see actually, can you see it? Yeah, here, hold this for a second. You see this little guy right here. This is actually, it's probably the descending aorta, which that's going to be on the left side. So if you're ever not sure, that's ways that you can kind of help figure it out.
As that RV gets blown out, that the difference between the tricuspid valve and the mitral valve is going to be less and less apparent as that RV dilates. I wouldn't use that as a hard rule if your RV is huge. I
mean, it's difficult when you're doing image review in person. You can just say like, well, I have the probe marker to the left. So if the probe marker is here and I have the probe marker to the left, this is the left side.
Yeah.
And then one more note, to get a good, so if you have a hugely blown out right ventricle, you actually, instead of having your probe like out laterally like you usually do to get a good apical 4, you can turn it inwards a little bit to be able to get the free wall. So this is actually a view that's called an RV focused view that you specifically, if you've already diagnosed it, it's enlarged, you can look a little more in depth at the RV free wall by doing this RV focused view. All right. Sorry, go ahead, Ben.
No, just quick comments. So as a sanity check, if I see a blown RV, I'm always looking for make sure I'm looking at the correct side of the heart, regardless of which way the probe marker is. And I think that if you just lay it down a little bit and get the apical 5, you can really quickly tell where the aortic outflow tract's coming out.
That's another one. That's great.
And then the last thing is like the moderator band. And it's not always there, but sometimes you're like, oh, I can kind of see on that blown RV, there's a little moderator band there. But maybe it's just coming through on the video here as an artifact. It's hard to say.
Yeah, it's. I mean, maybe there's a little bit of a moderator band right there. Maybe you can't see it on this view right here, but yeah, moderator band is something that you'll see at the apex. Actually, Ben, when I was an intern, and I think you know this story. When I was an intern, and just in case people don't know, Ben was my ultrasound director when I was a resident. The first time I saw a moderator band, I freaked out and thought that was like a clot. Yeah, I thought it was a PE, and we called a stat, echo from the cardiology department, and the technician was actually very nice to me, and she's like, no, like it's a normal structure. And so I learned and was humbled, and now I always think about the monitor band as a great learning experience for me. Ben, is it okay if we move away from the heart?
Sure, I guess so.
This is a finding that is out there. I've just so rarely seen it that it wasn't even in my mind. Do you guys have any idea what it is that I'm looking at here? If not, totally cool, because I didn't know until I researched this for a talk I was giving. Otherwise, and this was within the last year. Any thoughts?
I mean, it looks like eyeball, but there's a lot of other stuff going on. Yeah. It's not a clean looking eyeball.
Ben, do you have any ideas?
Yeah, my first thought was, it's either eyeball, an aorta, or a baby's head. It's one of those three.
Ectopic pregnancy. Yeah.
Yeah, but one way to know is to actually just think about where you're putting the probe. It's just
you're still teaching me.
Yeah,
I'm I don't know how many years out of residency, and you're still teaching me every time we talk, Ben. It's amazing. So this is
no, it's not the aorta.
It might be the baby. I don't know. Nobody knows. So this is the eye right here. This right here is the optic nerve, right? So just to orient you. And I'm going to pause it right here. Ben, you and I, we talked about the fact that we're music people. Ben, do you know Ben plays the trumpet very well? And he was in you were in marching band and stuff in college, right?
I was.
And I was a music major in college. I play the viola. And then you are really good at the guitar.
Ding, 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 ding.
Really good. He's great at the guitar. We actually jam out fairly frequently. This a little bit looks like a guitar pick.
Oh, I see. Okay,
you see, it's a little bit like a guitar pick. They call this the guitar pick sign.
Yes.
Due to this right here, which is a retrobulbar hematoma. And so what's happening is it's basically compressing, and so the eye should be nice and circular.
For sure.
And it's not. It has a guitar pick because the posterior part is actually being compressed into a bit of a triangle. So this is what a retrobulbar hematoma looks like on ultrasound.
I will say I was thinking trauma, but not that I picked up on the retrobulbar hematoma, but because of everything that was going anterior, we're seeing a lot of soft tissue edema.
There's air actually right here. There's a chunk of air there, a chunk of air there.
So I think either infection or trauma, and then that's an awesome pickup in the posterior area there too.
That's actually interesting that you picked up the increased edema up here as well as the air in that edema, there, which honestly I'm just so focused on it's a cool guitar pick sign that I didn't even realize that. But yeah, so this is guitar pick sign indicative of a retrobulbar hematoma. There could be maybe an enlarged optic nerve sheath diameter, although I didn't do the measurement.
Yeah, but I kind of agree. It's pretty well defined, and who knows if this person had this much facial head trauma, maybe. It's a good catch.
So did the patient get a canthotomy?
It just discharged. I don't remember. Sorry. I'm sure that they had a vision preserving procedure, which I like doing lateral canthotomies because they're not that complicated, and they will save the patient's eye.
Yeah,
which I think is super important. It's like a pericardiocentesis, but if you don't do a pericardiocentesis at the right time, the patient will die, which is a big deal. And then if you don't do the lateral canthotomy, they lose the vision, which is also bad, but less life threatening. All right, this is another fun one. I didn't want to just put regular retinal detachment and vitreous detachment stuff on here. So this is right here. I've heard Ben describe this as the eye nipple.
I did not.
Ben has literally never said that. That's what I said. I call it the eye nip because it kind of looks, you know what I mean? It looks, it's sticking out. And this is actually papilledema, which is just something that, sorry, Yeah, papilledema. That's the word I'm looking for when the optic nerve sticks out into the posterior part of the eye. You can actually have papilledema without an enlarged optic nerve sheath diameter, and you can have an enlarged optic nerve sheath diameter without papilledema. So they're not necessarily like you have one, you always have the other. Although in this case, I will say you definitely have both. There's a measurement. It's 0.6 millimeters to 1.6 millimeters, I think is the number. If it's higher than that, then it's considered like papilledema. You can actually like measure that. Have you, before I was like looking specifically for this, Ben, I didn't really see this a whole lot, but now that I like, my mind knows about it, I feel like I'm seeing it way more than I used to. Have you seen this?
Yeah, I have. I think there's always a little bit of a slight bulge there. Like just the optic nerve with a normal, it's ever so slight and subtle, and even a normal patient.
Yeah.
So if you just start to fan through and look at the optic nerve sheath, just kind of like train your eye up to the, the posterior vitreous area where the retina is. There's always a little bit of slight bulge there, but that's very dramatic there.
Now, are you guys using this for your pseudotumor patients? Like a workup of a new pseudotumor, is this reliable enough, or is it at least a good starting spot?
I don't know the data. I use it, but I don't know what the data is.
Yeah.
I take it into like the average number between both eyes, and then clinical context using some Bayes theorem kind of in my mind. Not any specific numbers, but like if it's 3.5 average and my patient's kind of like intermediate probability, I'm like, okay, I can treat your headache and have you follow up. But if it's if it's more borderline, but they have a really high pretest probability, I might go ahead with the LP.
Yeah.
No, that makes sense. That's great.
Yeah, I would love to see the correlation with the LP pressures.
Yeah,
I mean, maybe that's the study that already exists. I don't know.
Well, they've done it with optic nerve sheaths with endoventricular drains.
Yeah.
So the measurement on ultrasound correlates actually really well to the CT measurement of the enlarged optic nerve sheath diameter. When you look at it with the EVD, it's not great, but it's like high 80s sensitive and specific. It's like high 80s or low 90s. So it's not perfect, but it's pretty good with actual, and the cutoff is usually 20 to 25 millimeters of mercury out of those EVDs, those endoventricular devices.
Cool.
Now, where would you measure on this one? Can you pause and show me where you'd measure from on your optic nerve sheath diameter?
I'm a little bit on the oblique side with this, but I'd probably just find the most pwned up area it is. So probably like right here. And I live in the South now, so I say things like that. Is from here to here. So that's probably where I'd measure it. Like,
and then for the nerve sheath, how about the nerve sheath?
The nerve sheath, I mean, you got to do your 3x5 or whatever, but I don't know how, as long as things are, upright. Like I'm obviously to get this view, and just because I'm able to see like this kind of circle right here, and this is a bit on the round side, I'm probably on the superior eyelid, angling like the probe tail up with the beam a little more posterior is probably how I'm measuring this. So if this is the case and I'm hitting it from the top, it'd be a little tricky to know exactly like where to measure it, but I'd probably just find the biggest spot and then just like try to measure down the 3 millimeters to see if it's the 5 millimeters across.
Yeah.
I had one of these recently where it looked kind of like that, where the nerve sheath looked very small, close to the optic nerve, like close to the retina.
Yeah.
And then as you got like right below 3 millimeters, it like doubled in size. Kind of like if you fan through, see what I'm talking about? Like just kind of.
No, you're right. Yeah.
And so it was really tough to know how to interpret that. Like you're like, oh, it looks nice and small and tight, and then you get down there, it looks huge.
Yeah.
Ben, do you ever wonder why we measure things at 3 millimeters and not 4, like from the retina?
Because somebody studied it that way.
Yeah. Yes, you just it has that great pearl, and you're just like, yeah, it's in there.
I mean, I don't know. I'm just like assuming.
So they did anatomical like studies, and the optic nerve on average is the widest. Because you notice, like, if you do like an optic nerve sheath diameter measurement and you have the depth, let's say you have it go back 10 centimeters, right? Like super far back. It looks like it's continually increasing in size. But at about 3 millimeters, that's the biggest. And then it usually gets a little bit smaller just past that. And so there's a bit of an artifact that makes it appear to be larger.
Yeah.
So that's why we usually measure it at 3 millimeters, because that's in cadaver studies, that's like, and MRI studies, that's the widest. And everything distal to that is actually an artifact. It's like how you have edge artifacts, right? So essentially like an edge artifact coming off of the end. But that doesn't mean just because that's the average, like somebody's biggest like point might actually be 4 millimeters back instead of 3. So I don't, that's a tough one.
Then what do you take? You take the convention because that's what's validated, or you find the biggest one? I don't know.
I probably like in that situation, Ben, I mean, you're more of an expert than me, but in that situation, I'd probably measure it at the widest part. Like No, I don't know what I do. Because if it keeps going wide, how do you know what the widest part is? You don't know where that
you'd end
spot
up
is.
just keep going.
I guess you're just stuck at the 3, Ben.
I kind of feel that way too.
You just have to.
You're stuck with the convention.
That's hard. I guess just CTM, Ben. Just get the CTM.
Just put the device in. And
Just put the endoventricular
see what
device.
the pride.
Look, there's 2 livers. So as 2 spleens would be what it would be. This is like one of my favorite things to do on ultrasound. It's like look at lunges. This right here is a spleen, a little bit of fluid beneath the diaphragm.
Yeah.
I know this is left-sided because of this right here. This is the stomach. And then right here, we have a bunch of bad goo.
Yeah, that's awful looking.
This is one of my favorite things is pneumonia. I love diagnosing because if you see this, you've ruled in pneumonia. You don't really need to do anything. Of course, clinical context, but we're seeing static air bronchograms up here, and right here, wait for it, right there.
Yeah.
See these things coming out of you?
Yeah.
Some dynamic air bronchograms, which are thought to be highly specific for pneumonia. Now, I'm not going to always say it's 100% the case because it's not really been studied well enough to be able to say 100% of the time you see dynamic air bronchograms that's definitely a consolidation. And I will tell you that I've seen 2 like severe drowning patients, like they're intubated unconscious drowning patients, and they have dynamic air bronchograms. So the physiology for how the artifacts are formed with a pneumonia and with drowning are the same. So that's why it looks the same. But because of that, like I'm not going to say the only thing that has it is pneumonia. It's clinical context, right? This person has a cough and a fever.
I think consolidated is probably a good
You're right.
arch to fill that. Yeah.
Man, I have so much like patience and respect for radiologists now because it truly like you can't and
sterility cannot
to be fair.
assessed.
Exactly. To be
that's
fair,
true.
like it's not like I didn't have respect for him before, but before I did a lot of these image review sessions, I get frustrated when they'd say clinically correlate. They give you this wide differential and say clinically correlate.
Yeah.
But when you read the ultrasound literature, you do ultrasounds, you do have to clinically correlate because it could be a bunch of different things depending on what the patient's history
But
is.
that's half the value of doing our own point of care ultrasounds is that we're fitting it into exactly what we're seeing bedside, and that's how we're increasing our test characteristics.
Exactly. Whenever I see one of these ultrasounds like this, I actually quietly say to myself, clinically correlate, Ben. Clinically. And then in my mind that happens, and then I come out with an answer.
You just mutter under your breath.
That's right.
I like that.
Because I've seen a lot of mucus. Maybe I'm trying to recall if the air bronchograms are there or not, the dynamic. But a lot of mucus plug patients will have heavily consolidated
Yeah.
lungs like this, allostatic lungs.
You're right. Cool. Ben, I think we could probably end there. What do you think, Ben?
Yeah, looks good.
Hopefully that was helpful for you all. If you'd like to contact me, go to Twitter, and my Twitter username is @CoreUltrasound. You can also email me at ultrasoundpodcast@gmail.com. Hope to hear from you soon, and happy scanning.